Mechanical chopping. Well, this is the name of this video presentation. And why mechanical chopping? Because sometimes we end up having a case, a cataract, which is soft, which is crumbly, which is gummy, just like we have in diabetic cases, and the cataract refuses to break. It's very difficult to hold the cataract. So here I have tried to demonstrate a technique which is I call mechanical chopping, and in which we just chop the nucleus using a long ball tipped Sinski hook, and without any vacuum or any power we'll just mechanically separate and chop the nucleus. Just it will be shown. By this time I have already initiated the rhexis slowly, and I am aiming for a rhexis of about 5 to 5.5 millimeters. Half of the rhexis is done, and now I am going to take a micro rhexis forceps and complete the rhexis. In majority of the middle-aged patients who have these crumbly diabetic gummy cataracts, I have seen that the nucleus doesn't prolapse out of the capsular bag on hydrodissection, and if the nucleus prolapses out, then we can just do a tilt and tumble technique by prolapsing one pole of the nucleus out of the capsular bag. But in these cases I have seen, even after a good hydrodissection and injecting the wave, few waves, 2-3 waves, still the nucleus doesn't come out. In these cases, then there are chances of having a bowel formation, and once we have a bowel formation, then things become really difficult. And on the top of it, if we have a small rhexis, then still the things become even more difficult. So this technique is slightly different technique, although it has got a learning curve. I have also not done many cases with this technique. I am going to demonstrate in a moment. Hydrodissection, a good fluid wave has been passed, the nucleus is tapped, the mobility is confirmed. I will do some hydrodissection on the other side because there are some cortical elements to the cataract, and when we have some cortical elements, then the corticocapsular adhesions are really tight and they need to be broken. The nucleus should be freely mobile, and now is the time to inject the phaco needle into the eye. Here I am planning to do a long thin trench, and then I will try to just make 2 heminuclei out of the whole nuclear mass. A long thin trench, very less power, about 30, and vacuum about 70. I am making a long thin trench. After reaching about 60 to 70% depth, I have taken a long ball tip Sinski hook type of instrument, and I am going to try to make 2 heminuclei and just try to just break it into 2 pieces. Still it is soft and so much gummy and in nature, it's difficult to make 2 pieces. So now what I was talking, the nucleus will be divided using mechanical forces. The Sinski goes, that ball tip chopper goes below the intercapsular margin, hooks the equator of the nucleus, then both the phaco needle and the Sinski are brought together so to have a decent cut. Still I have not got any clean cut. Still I am trying to just manually break down these pieces. Again I take the ball tip Sinski below the intercapsular margin. No vacuum or power is being used now, and both the instruments are brought apart, and now I have got a pie shaped nuclear fragment which I am going to emulsify using a power of about 25 to 30 and vacuum of about 300. Once we have a single separated piece, then we have got some space in the capsular bag, and it is easy to mobilize the remaining part of the nucleus. These cataracts are so soft that the moment we use very less power, here I am using about 10 phaco power, and still the nucleus just crumbles in front of the phaco handpiece. Vacuum here is about 300. This is a venturi based system, we don't need to adjust the aspiration flow rate. Machine automatically is adjusting it. So almost half of the heminuclei is being removed. Well, in these cases, if we are not cautious enough, we tend to have a bowel formation, and then many of the surgeons would panic. So this is a good technique to just get this nucleus out of the capsular bag, and manually I have just pulled out the nuclear pieces out of the capsular bag, which will be then emulsified. Because the size of the nucleus has substantially reduced, so it was easy to just use a Sinskey hook to just manually take out all the nuclear pieces out of the capsular bag into the entry chamber. With very less phaco power and vacuum about 350, safely all the nuclear pieces can be just emulsified. So this technique has got some learning curve. It's a good idea to always stay in the entry capsule so that we can have a good view of the entry capsular margin. In these cases, it's very important to visualize the entry capsular margin, because if you cannot visualize the entry capsular margin, then there are all the chances of having a zonal dialysis, because you have to be very sure that the ball tip Sinskey is going below the entry capsular margin and not on the top of it. And once you are sure, then it's not a difficult game to just manually crack down the nuclear pieces. So after the nucleus has been removed, time to remove the cortex. And here I am using my coaxial system, vacuum of about 400, total height about 100. Subincisional cortex is removed, and once we have a very good cortical cleaving hydrodissection, this cortical removal is not a tough job to do, and one should always just rotate the nucleus after hydrodissection just to loosen out some cortex, and it won't be much of a difficulty. Well, basically you can see my video of cortex aspiration. I have made a video how to remove the cortex using Simcoe cannula, bimanual irrigation and aspiration, as well as coaxial aspiration. And in different cases I have demonstrated how to use different instruments. You can always watch them. I'll share the link. And the basic idea of having a very good cortical aspiration is we have to have a very well-formed entry chamber, because if you don't have a well-formed entry chamber, then all the chances of having complications of a PCR or zonal dialysis. So after cortical aspiration, I've filled up the bag, and here goes single piece monofocal aspheric hydrophobic intraocular lens. Reading haptic goes in the bag, and now the trailing haptic will be just dialed in a moment. The lens delivery was not very smooth. The trailing haptic is in the incision. We just push it inside. And using the Sinskey hook, just be dialing it in the capsular bag. For mechanical chopping, I feel using a ball tip Sinskey hook is a good idea, because we don't have any sharp edges, and where there are very less chances of damaging the pituitary capsule if you just take some time and precautions how to move the instruments in the eye. And It's a good technique to learn, although it has got some learning curve. Nonetheless, it's a good thing to avoid the bowel formation, which is even more difficult to manage and ultimately many times leads to some complications. So now I'm going to remove the viscoelastic both from behind the intraocular lens as well as in front. Vacuum air used is about 450, bottle height about 110. That's it, the case is done. And now is the time to close the side port and the main port. Some oxyfloxacin is instilled in the eye, intracameral. Main port is being hydrated now. And now the side ports. That's it. I hope you like the video. Do like, share and subscribe the video if you like it. And I hope this is going to help you in your learning curve. All the best. Do share my video if you like it. Thank you so much. Keep following.